Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon and welcome to VITALS, Visionary Health Leadership in Action. My name is John Langell, President of Northeast Ohio Medical University and the host of VITALS. Now entering our second year, VITALS continues to be a powerful and growing venue to discuss our nation's most difficult struggles in healthcare and an opportunity to hear from national leaders who are using the tools of VITALS to affect positive change. I'm very pleased to introduce our speaker today, Mr. Patrick Kennedy. Mr. Kennedy is a former U.S. representative and founder of the Kennedy Forum. During his time in Congress, Mr. Kennedy was the lead author of the landmark Mental Health, Parity, and Addiction Equity Act, which requires insurers to cover treatment for mental health and substance abuse disorders in a similar way that they treat illnesses of the body, such as diabetes and cancer. In 2013, he founded the Kennedy Forum, a nonprofit that unites advocates, business leaders, and government agencies to advance evidence-based practices, policies, and programming in mental health and addiction. In 2015, Mr. Kennedy co-authored the New York Times bestseller, A Common Struggle, a personal journey through the past and future of mental health illness and addiction, which details a bold plan for the future of mental health care in America. In 2017, he was appointed to the President's Commission on Combating Drug Addiction and the Opioid Crisis. He is also the founder of Don'tDenyMe.org, an educational campaign that empowers consumers and providers to understand parity, rights, and connect them with essential appeals, guidance, and resources. Co-founder of One Mind, an organization that pushes for greater global investment in brain research. Co-chair of Mental Health for the U.S., a nonpartisan initiative designed to elevate mental health and addiction in policy conversations during the 2020 election cycle, and co-chair of Action Alliance's Mental Health and Suicide Prevention National Response to COVID-19. Clearly a great leader and advocate for mental health in the United States. I turn the floor over to Mr. Kennedy.
Thank you very much, John. I appreciate that very kind introduction. I also appreciate the opportunity for being back at NEOMED. I can recall many years ago, I had the chance with our late great friend Jay Gershon to come out and participate, along with, I know, Rick Keller, who's on and who we'll be talking with after my brief remarks. But I just want to salute Jay and his memory. He's done so much for NEOMED, and I know all of you join me in paying tribute to him and thinking of him at this time. Let me thank you all for what you're doing to advance thought leadership and medical leadership, really public health leadership in terms of how do we change the trajectory our nation is heading in with respect to the condition of its people, both mentally and with all of the other physical challenges we have with COVID and the like. one of the reasons why I was so honored to join this discussion is that I've been really interested in getting more connection between COVID, the pandemic, and the epidemic of mental health and addiction that is obviously been exacerbated because of COVID. And the kind of innovation that you're all part of today, I think, is the future of what we will ultimately need to do across the board in addressing all healthcare issues. And that is to obviously reconnect mental health with the rest of the house of medicine. If you ask me, why is it that we have escalating suicide rates that are unabated, even amongst now even greater rise amongst children? Why are we continuing to see higher death rates from addiction, overdose, opioids, and many others, including alcohol, which continues to be overlooked in this debate? It seems to me that the fundamental missing piece is that mental health and addiction has always been seen as something separate from the house of medicine. And it's really the original sin of our current crisis, is this bifurcation between mind and body. And my work, as John mentioned, throughout my life has been to try to reconnect the mind and body. I had the honor, as John mentioned, of being the sponsor of a bill in Congress that merely said that the brain is part of the body. It's not a very revolutionary concept, but it took us over 13 years from introduction to of that bill for us to ultimately get it passed. And in large part, that was because insurance companies continued to balk at the notion that they had to pay for brain illnesses in the same way they pay for all other physical illnesses. Obviously, there are greater costs and liabilities if you now have to pay for depression, anxiety, addiction, and the like. And yet, what the science has told us through the impact model and many other research studies is that actually, in reality, when you spend more on mental health, you actually save more in terms of the total cost of care. So rather than seeing mental health as some additional burden on the part of payers, we're now recognizing that it is actually mental health that is the secret sauce to reduce total cost of care, because you cannot ignore the impact of depression on increasing the rate of heart attacks by 4 times if you have depression, or the impact of alcoholism on diabetes, or the impact of any of these chronic illnesses on patient compliance with the rest of their medical treatment. And so we know that from here on out, we need to embed mental health into the DNA of all healthcare. And we tried to start to do that with the Mental Health Parity and Addiction Equity Act, which basically says that whether you're inpatient in-network or outpatient in-network or inpatient out-of-network or outpatient out-of-network, or you're needing emergency room services or pharmaceutical benefits, you must receive, as a matter of federal law, the same continuum of care, primary care, secondary care, tertiary care, that you would receive if you were being treated for cancer or cardiovascular disease or any other chronic illness. That's a big statement. And furthermore, we said you can no longer have a lower lifetime caps, which means that you would blow through your benefits early on in your life if you were like me and had both a mental illness, a bipolar disorder, and a co-occurring addiction. By the time I was 22, I had already maxed out on my lifetime limit. So we got rid of the lifetime caps. And we said no higher premiums for people with mental health conditions, just like we prohibit that discrimination from occurring in other physical ailments. And we made sure there was no higher deductibles. But the thing that we've never been able to get our arms around, and which is why we started the don'tdenyme.org, is that we haven't been able to get our arms around kind of the legacy of discrimination when it comes to the judgment by many providers and payers when it comes to limiting access to mental health. It's almost kind of implicit bias, like we see in the context of our racial pandemic, where people are unaware of their inherent bigotry, their inherent ignorance around how they view people who have a mental health or addiction diagnosis. Because in most people's minds, mental health and addiction treatment doesn't work. At least anecdotally, people all have family members who really were never, quote, able to get it together. And the reason why that stigma persists is because we have not adopted those evidence-based interventions that actually produce better outcomes. We've never insisted upon that within the provider community. So I have been a big champion of making sure mental health is provided for by insurance companies reimbursing for it, but I'm equally wanting to hold our providers accountable to treating their patients based upon the latest evidence-based interventions. And tragically in our country, according to folks like Tom Insel, only about 60% of our provider community adheres to anything close to evidence-based treatment protocols. Because as we know in our country, we take a one-size-fits-all approach. We do not distinguish between the specific types of cognitive behavioral therapy that are needed to treat depression versus anxiety versus eating disorders versus any number of different addictions versus other forms of serious mental illness. We kind of have this one-size-fits-all approach, which means that many people's experience in getting treatment is that, well, treatment doesn't work. In fact, treatment does work. The problem has been we have not deployed the types of evidence-based treatment that can really make a difference in people's lives. And you layer that on top of the fact that we never treat people until they're, quote, stage 4 in their illness. As all of us know, we try to get our regular cancer screenings. And part of that is because we acknowledge today we want stage 1 screening. We don't want to have to wait till you have stage 4 cancer. We don't want to have to wait till you have stage 4 diabetes. There's no wonder so many of our fellow Americans are dying of untreated mental illness, whether by suicide or overdose, because our nation still does not intervene early enough in people's illnesses to really help make that difference. Because if we intervened earlier, like we do with cancer, we would have the same types of survival rates, I believe, that we've now seen remarkably over the years be part of our efforts to better treat cancer in our country or cardiovascular disease. So, and it's interesting when I go to my doctor, my doctor asks all about my family history of, cardiovascular disease. What's your family history of cancer? But physicians never ask, what's your family history of mental illness? What's your family history of alcoholism and addiction? And as all of us know, for the same reasons they ask about our predisposition for cancer and heart disease, we need to appreciate that the illnesses of mental illness and addiction are largely heritable illnesses, meaning they're biologically we're biologically predisposed for these illnesses based upon our genetic makeup. which then argues, why don't we do much more in terms of early intervention? And I believe if we're going to really take on the enormity of this challenge, of this public health crisis of mental health and addiction, we must address it public health wise, and we need to put a particular emphasis on prevention. And in addition to treatment, we need to look at secondary and tertiary forms of prevention, which means we need to support recovery. So many people, including myself, over the years have cycled in and out of drug rehabs and in and out of psychiatric hospitals. Why? Because our reimbursement system, once again, discriminates against these illnesses as illnesses only seen as acute and episodic, as opposed to illnesses that are chronic illnesses and that which need to be treated along a continuum for a lifetime. Today, I'm over 10 years sober from all drugs, alcohol, and mood and mind-altering substances. And I'm able to do that because I have supported recovery. But that recovery is not paid for by my insurance. That recovery is made possible by my peers in recovery and by the support systems that I have put in place myself. We shouldn't have these illnesses be do-it-yourself illnesses. We need to have our payers and our providers help us manage our illnesses on a chronic care basis, just like our healthcare system treats other chronic illnesses through a chronic care management template. Finally, let me just say that when looking at this issue, we really need to look at integrating mental health, not only within our healthcare system, but we need to integrate it with our education system, because our kids, especially in these days, so traumatized by COVID and their overall pre-existing vulnerability due to overexposure to technology and the like, are really suffering from much higher rates of anxiety and depression. We need to be intervening in where kids are, since over 74% of mental illnesses occur before the age of 15. If we're not really incorporating mental health into education, we're missing out on one of the greatest opportunities to make an impact in this area. We're missing out on the impact to really employ mental health and addiction in our criminal justice system for justice-involved populations, many of whom are largely in prison because of early childhood traumas and because of untreated mental illness and because of untreated addiction. It is a crying shame in this day and age we're spending so much money on criminal justice when that's really a default for a lack of a mental health and addiction system. And finally, why we don't have our workers' comp and our workplace programs really attuned to the mental health as being part of the overall workplace culture. Maybe we have an opportunity to do that now that we're seeing a great churn in the employment in this country and the focus that businesses have now on trying to make sure that their returning workforce, no matter how they're working, whether virtually or hybrid or in the office, have strong emotional supports, and that we're entering a whole new era of culture change when it comes to recognizing the value of that to the bottom line. Even more so to how are we going to spend more on healthcare on the physical side, because the payoff is not only in reducing total cost of care, the payoff is in a more productive workplace with less disability and obviously a greater satisfaction and less turnover within the employment of those businesses. So we are looking at mental health in a much more holistic way. I'm honored that I've had the chance to participate with all of you today at VITALS. You all are leading discussions on these important issues, and how do we dream about the kind of health systems that are going to produce real results going forward based upon the innovations that many of you are part of in this important forum. And I certainly look forward to discussing this more with my good friend, Rick Keller, and thank you all very much for hearing me out. Appreciate it.
So thank you, Patrick. It's good to see you. I trust that the family, Amy and the family, are well. I know you guys are getting the tail end of the hurricane that just hit the country, and so stay safe out there. And I don't know if you're able to get out to the ocean this morning for your mental health care check-in, but it's good to see you. So I'm Rick Keller, president of PEGS Foundation, and I'll take a quick moderator's prerogative here and talk about the impact that Patrick personally and professionally had on our foundation. So Patrick mentioned his relationship with Dr. Jay Gershon through a relationship they had, I think, at Research America. They became friends, and we announced, we're doing a grand announcement, and we're a great partner in NEOMED. And he came and helped us announce it. And in part of that visit, you wanted to go see Dr. Bob's house because AA, Alcoholics Anonymous, founded here in Akron, had a great impact on your life. And you had this just amazing experience. And I had just met you, like we had lunch, and then I'm tagging along, right? And you counted the steps into the house and coming out, and you turned to me on our way out of that house, and you said, "This was one of the greatest miracles that's ever come to the world, came out of Akron. The next miracle needs to come from you guys in mental health, make it happen." And I was like, like in the military, as a former Green Beret in the military, we call that commander's intent. And our founder had given us this tagline of think bigger. And we kind of thought we knew what that meant. But you brought it to life in the sense of how should we action ourselves as a philanthropic partner and knowledge broker. And I've always appreciated that. And it's been a great friendship and relationship. And, also shout out to your late uncle, who is the reason why Green Berets can wear the Green Beret, right? By presidential memorandum. Like when the commander-in-chief encourages generals to do something, every once in a while they do. So thank you for all that. So a couple questions that as I was listening to you and thinking through this, early on, we think about deaths of despair, and you talk about what is the cost benefit of behavioral health or these mental health disorders, that at the end of the day, it's not a burden, it's not an expense, but it's actually potentially a force multiplier. Or as an employer, like if you could just give a quick thought about why should an employer be motivated to shop for that insurance plan or that payer plan that has a better array of behavioral health services? What's in it for them?
Well, thanks, Rick. And I have to tell you, you really, the Green Berets, when I had the chance to tour and rededicate the John F. Kennedy Special Warfare Center at Fort Bragg, North Carolina, many years ago, General Hugh Shelton, the first chairman of the Joint Chiefs, who came from being a Green Beret, took me around, and he said, he read my bio and CV, and he said, Congressman, we really support mental health. And I'm like, General, you don't have to tell me that. The building has my uncle's name on it. I'm going to appropriate all the dollars I can for this place. And of course, he immediately felt like I hadn't obviously taken him seriously. And he said, no, hold up, Congressman. He said, we have more mental health per Green Beret than any other branch of the service. And I said, come on, General, I know enough of this. We became friends. I said, enough of this. I said, Green Berets don't need mental health. They jump out of the sky and they land in the water. They swim without breathing for 5 miles. They hit the beach. They speak 6 languages. They take out their target and they're home reading to their kids by dinner time. I said, these are the Green Berets. Why do they need mental health? And General Hugh Shelton said to me, I thought I'd heard it all because I've been in the mental health advocacy for some time. He said, we look at mental health as a force multiplier, to your exact words, Rick. And I think employers need to take a lesson from the Green Berets and from the military. The military has pioneered so many things, advanced so much in our society. And they clearly have advanced performance. And they know that an operator who they've invested millions of dollars in is not going to be able to meet their optimal potential if they're in the theater of war, if they're in a stressful environment, whether they've got their teammates around them and they're trying to accomplish an objective, if they have intrusive thoughts, in other words, if they're worried about their spouse, worried about their kid, worried about some of the other things that everyone always worries about, they would then be compromising the safety of their fellows on the mission, and they might be compromising the mission success itself. In other words, the military is investing in training our soldiers to have mind over matter, to have the psychological resiliency so that they can prepare to have psychological Kevlar. In other words, where they are prepared to take the assaults that are coming stress-wise, because the weapon of terror from terrorism is a psychological weapon. And we as Americans who are fighting a global threat of terrorism need to adopt a psychological response to that psychological weapon. That is also true in business. And we have to think of mental health in the phrase that someone once said to me, you don't have to be sick to get better. In other words, all of us are in a continuum. Some of us have been further down the road of dysfunction and disability due to their mental illness than others. But all of us, by nature of being human beings with brains in our head, have time to time mental challenges that we need to be better prepared for overcoming. And that means early intervention. That means being proactive, but also means if someone has trouble, don't wait for it to get worse. And I appreciate the question. Sorry for the long-winded answer.
No, it's awesome because your passion is palpable and it comes through. And we've got a question that came in from Facebook Live, and I think it goes that I would put this in the bucket of workforce, right? By 2025, there's a shortage today, and it estimated, and just in terms of psychiatrists, 15,000 psychiatrists short for what we could use in the medical health field. What do we have to do to address that, and how do we think about, and maybe there's your personal experiences like integrated care. We all get, most of our care begins with our primary care provider. What can a place like NEOMED, or what can innovative health leadership do in order to address those workforce shortages that are out there?
Well, you're absolutely right. The demand is so great. The supply is nowhere near meeting the demand. So we have to be innovative in how we put solutions out there that can help meet the demand and also help us triage and risk stratify which people need the more acute treatment and make sure they get it. And then what can we put in place that doesn't require psychiatry, but that may require us doing a much better public health approach, because we know that your zip code is as important to your health as your genetic code. So, coming from a traumatic environment of extreme poverty, racial prejudice, domestic violence, so forth, coming from a home with an active addiction, we know how that wires kids, unfortunately, for, in many instances, a lifelong disability if it's not intervened with early. So there are a lot of things that we should be putting in place, because as the African proverb says, if you don't want to have to fish as many people out of the river, try to make sure not as many fall in. And that's got to be part of our strategy now, while we're trying to bring to scale, as you point out, collaborative care. And by the way, while we try to bring out value-based contracting. So what NEOMED can also focus on doing are, what are the kind of economics of value-based care, which can really emphasize this mental health is not kind of apples to apples, but how do we spend more on mental health, or stable housing, or food security, because that's going to stabilize someone in a way that all the med management is not going to be able to do. And so we really need to think anew about healthcare not being just clinical, but in recovery, we have a recovery capital index and scale, recovery capital scale, which tells us, if you look, why am I sober today? Because I've got a good 12-step group, to the point earlier. I've got very supportive family. My spouse entirely understands the disease of addiction, participates in recovery herself for being a family member. My kids know my friends and family, and of course, being in this advocacy world, make sure I'm surrounded and have another layer. And I work heavily on dealing with intrusive thoughts so that I don't get sidetracked by counterproductive thinking. Now, that's essential to my recovery, but I guarantee you, everyone listening out there could benefit from understanding how to intervene when they have a thought, so that that thought doesn't become a feeling, and then that feeling doesn't become something that they act upon in a way that is counterproductive to their self-interest. Who would have imagined that we don't have to be, on a treadmill and reactive our whole lives, but rather we can be more intentional, and we can actually have agency over our own actions, which to me is my challenge as a person suffering from addiction, which is really just being in a total reactive mode all the time. So innovations are going to come in lots of forms, but if your organization and the group of assembled people watching this can think about what are all the other kind of maybe non-clinical and clinical approaches that can be brought to bear to bring the greatest fulfillment of a person, then you can see reduction in all the things that contribute to their ill health. So I think you're absolutely collaborative care, big deal. And training up, by the way, training up all of our medical providers, so that when my sister went to get treated for cancer and she was given the diagnosis of lung cancer with 6 months to live, that her oncologist would immediately be able to do a mental health intervention while giving that diagnosis, and put her in touch with depression counseling and trauma counseling, because she was a mother of 2 teenagers worried about their future. The fact that medicine, and you're taking people with fatal illnesses, that they have no training in mental health, it should be intolerable to all of us in the medical field. And we cannot say, oh, psychiatry, we don't have enough psychiatrists. It's not the job of psychiatry. They're just the specialty down the line. It's the job of every physician, every nurse, every paraprofessional to be better prepared to treat the whole needs of their patients.
Thanks, Patrick. No, I think you're right on, and I think the word that came to mind as you were answering that was that there's a continuum of care. It's not this acute. I think when you're speaking earlier about this acute episodic, like, hey, I broke my arm. Yeah, I tell the story of my youngest daughter who broke her arm went to the local children's hospital, got to pick a purple cast. Fast forward, 8 years, now she's self-harming, and it's a whole different continuum of care. And she walked into that hospital thinking like, they're going to fix me tonight. I'm like, I hope, but we know that's not how these illnesses, that's not how it happens. So I appreciate that. And you also mentioned a little bit around stigma, and Paul, and I'm gonna give it a shot. Paul Watuna Kunicorn, I think I got it right. They're great friends of NEOMED. Has mentioned, he's got a question. Physicians are often reluctant to seek treatment themselves because of the concern that any diagnosis will follow them, and they may be penalized for it, either by state medical boards, hospital credentialing committees, malpractice insurers, and et cetera. All still ask about any mental health diagnosis on their applications for privileges or coverage. Lobbying by physicians to change this at the individual state medical board level has been largely unsuccessful. The fear of reprisal and fear of stigma still exist. What avenues do you think will be most successful to change this?
So thank you, Paul, for that. So I've been in all kinds of recovery groups, including lawyer recoveries and physician recoveries when I was back in Rhode Island. I had support group with a number of physicians. As we know, recovery can work. Physicians, pilots have 90% recovery, over 90% after 5 years, complete abstinence. Why? Because recovery works if it's intensive and it's delivered in a chronic care manner. And by the way, it uses something called contingency management. So one of the things we fail to use, it's an innovation that's been on the books for decades. You can call our good friend Nora Volka, head of NIDA or NIMH, any of the institutes. It is one of the most sound evidence-based interventions that is never employed, and that is contingency management. So I live near Atlantic City today in New Jersey. They have figured out behavioral management. They know how to get the dopamine receptors going. And when you've been drained of your dopamine receptors because of addiction and acting out in all kinds of different ways, you have a low dopamine level. It's hard for you to respond to treatment, see a benefit. You need to have a reward, and you got to marry it with a carrot and a stick approach. So I'm not for abandoning our drug courts. I think our drug courts are enormously powerful motivation for people to get treatment, but we ultimately have to show people that they get rewarded. And there's now people can get points and rewards for, just doing the simple, going to their therapy, getting a good drug screen, going to 12-step, meeting with their counselor. If you do things, you can get benefits that can accrue to your support and recovery. I mean, these are the neurobiological underpinnings of support recovery. But to Paul's question, that's been the problem within the military. As you know, Admiral Mike Mellons, when he was chairman of the Joint Staff, said, I implore all of my fellows in the military to go seek help, because the thing that's most dangerous, most threatening, is if you don't get help and then you end up putting the lives and well-being of those around you in jeopardy, because instead of getting the help that would make you a better partner to your team, you're now impinging the well-being of your team by you not being well. Like it's all in the attitude. And I think that that's going to be crucial. I mean, the worst thing about people hiding these illnesses is that they're jeopardizing the health and well-being of everyone around them. So I think we should be definitely tackling that stigma. I don't have this answer. I wish I could give Paul a really good answer to that. I would just say that, we need to get more recovery programs, more access earlier, more acceptance that this is a treatable illness, that people don't have to fear saying, no, I'm someone who suffered the disease of addiction. I am a reliable person because I have a reliable treatment picture. I know what that looks like. Others have validated what that looks like. I am a dependable employee. I am one of the safer people. If you want to look at who do you want to have, monitoring or being part of deciding for someone that's important in your life, someone who's been in recovery, who has those supports, who knows how to employ tools of recovery and stability. They're the people we want. And we don't want people who think that they're fine and that no one's disclosed anything, because those people are the ones that are more apt to be liabilities. We have to show, I guess my final answer would be, you have to change the liability to not disclosing as opposed to the liability of disclosing.
No, I like that. I think because that's the way to translate it over. And so thinking about, the different advocacy or associations, whether it's, do the two APAs, psychological and psychiatric, the AMA, or their associations. I mean, that's where I think this has to come from, to put enough pressure on the regulators, whether that, state by state or whether there's an opportunity nationally. But I think it all focuses back on that stigma question that I think you laid out really well. And I like that idea that you said of, it's flip the script, right? Let's flip it back so that there's more liability when it's not disclosed. That makes sense. Another Facebook Live question, and some of our work over the past year has demonstrated this around, how do we respond? So people with serious mental illness interact with multiple public systems. Oftentimes they fall into the public system because of the nature of these illnesses, their family has separated from them, or they're homeless, or they just don't have the access to care that they need based on zip code, and ultimately land in either boarded in an emergency department or they land in jail. How do we think about or frame this so that we can decriminalize these illnesses? That, hey, if I have cancer or I break my arm, I'm not going to go to jail. I might go to the emergency room and I'm not going to sit there, and I'm probably not coming back anytime soon, hopefully. How do we get ensure the right treatment's available when they need it?
Yeah, so, well, first of all, it's absolutely inexcusable in this great nation of ours that we allow people to have first onset schizophrenia, and they have to have an equivalent of about a dozen or more psychotic breaks before the system responds to them. Talk about flip the script. We need to have mandatory specialty coordinated care. It's the evidence-based upon first incidence of schizophrenia. If you did that, you would interrupt the pathology of the unraveling in the brain, such that people will not be required, if you will, because you got in early with the brain, to have their illness pathologize and become progressively worse and progressively more intractable, which then necessitates more medication, which of course the side effects of that medication make it very undesirable for people wanting to take that amount of medication. However, if we did first incidence and treated them properly, they would not require the same amount of medication as they currently do, because we wait for them to have multiple psychotic breaks. That is just something we need to do, because talking about this before, after not doing that, it just doesn't make any sense. For those that are currently, unfortunately, been cast aside and left to the confines of jails, institutions, the streets, we have to take a approach that marries what's best for them. And that's all about how do we finance that? Because what's leading to the fragmentation now is multiple different systems, right, that don't talk to each other, that don't coordinate with each other. What we need to do is develop a more integrated funding stream, because Lord knows we spend enough on serious mental illness just through the justice involved population. When you think about the arrest and the cost there, the cost to adjudication, the cost to sentencing, the cost of incarceration, the cost of probation, you have more than enough costs there to last a person a long time with premium treatment, premium. So, but what are we doing to provide stable housing? Because that's not happening. The med management's not going to make a difference. Supportive living. What are our clubhouse models? Why aren't we expanding clubhouse models? And peer supports, and have people have a continuum of care. Those are the opportunities so people don't have to fall through the cracks, because the way we currently deal with this, again, is all backwards.
Right. Yeah, I think that question highlights the extent of the problem, and also the opportunity of getting these two systems that are funded separately to think almost universally, how do these fundings flow? And hey, if I'm a business, well, I'm not really getting any costs. Well, you are, if there's a reduction in public sector costs that need to be supported by state or regional tax revenue streams. So
one thing what we might do, Rick, is there's 75% recidivism just in general from the state prison in 5 years. That's just outrageous. So, it'd save further victimhood because hurt people, and it would save enormous dollars if we reduce that recidivism. So imagine, like, we currently have health plans reducing readmission to hospitals, right? That's like a major benchmark. Why don't we have a kind of accountable care organization apply in our justice system, whereby sheriffs, other law enforcement officials are incentivized to reduce recidivism? Well, what would they get? They'd get bonuses, which they could put to more supportive housing, get more people with lower recidivism rates, make it an economic game, just like we've done with healthcare, where we've harnessed the enterprise value of keeping people out of the ER as the real value. Why aren't we doing that in justice involved? Because it would cost very little to provide supportive housing and supportive services for people with severe mental illness, who are the ones that are constantly cycling in and out of our jails and our prisons.
Thanks, Patrick. No, you're right on. And somebody had reached out and asked about the increase of deaths of despair, and I sent them some information from a fellow partner of ours, Wellbeing Trust, some information around the increase. And I know last year we talked a lot about the COVID curve and then the impending behavioral health curve that, unfortunately, as it increases, doesn't drop off in the way we see these COVID projections spike up and then come down. Usually once the behavioral health issues arrive, they don't go away that quickly. I know we were talking a year ago about this impending tsunami of need that's coming. Somebody asked on I think it's Facebook Live, but they asked, like, who's got it right? Like, if I'm going to be seriously mentally ill or I'm going to have an addiction, which country should I move to that has it figured out? And it's a tricky question because America is so big. You know, you could say, Sweden, but like that's a different country from us. But it's a curious question. Like, where is it? Do we feel, or do you know of? And maybe the answer is you don't know. It's a good place to be, and who's got it kind of right or is on the trajectory to have it right.
Well, the nice thing, Rick, is that we know the essential components of a system. Like we've just talked about the essential components of primary prevention, secondary prevention, tertiary prevention. We know what those look like. We know the impact of social determinants of health. We know kind of how to weave and braid all of these systems together. The point of the question is, how do we align the incentives so all of those disparate social services, medical services, community services, transportation services, education services, justice services, housing, that they come into play in a way that meets the specific needs of the patient, who may need more of one than another, but for whom all the systems get a better ROI if all of them are in it together. So I think we need, like when we talked about community rating and we talked about, these value-based contracts that CMS is now moving towards on a population base, I think we need to incentivize payers to do what they know works, because they are incentivized in reducing hospitalizations, reducing comorbidities, if you give them that incentive, they're going to pay for what the science tells us will work. But it's not going to work if we just try to look at this through a bunch of pigeonholes, like, oh, we got to have this. Yeah, but that without this or that won't be worth just having a single approach over here. So most countries that have a more comprehensive system are those with, based upon a more kind of national health program, and where payers are not incentivized to cherry pick and to push from their roles people who are going to be high cost, because when that happens, nobody benefits and people get bounced around. That's currently the problem with so many people with SMI and addiction, is they get bounced around. Everyone moves them on to someone else. No one takes charge. No one takes responsibility. But if we were able to underwrite that risk, say, here's what this person costs. If you can reduce it by 20, 30%, you get to keep a balance of whatever percent. I guarantee you we'd be solving this problem, because if it were contingency management, housing, transportation, food, family supports, what have you, those things would be paid for if they had discernible results. And of course, our medical system is not paying for those, as I said, so SDOH indicators that really do have a major impact. But we in Rhode Island, when I was first starting out, got all the payers to pool some money for prevention that could go for investments in population health that none of them as individual payers could justify. First, because, the kids, secondly, it's so long down the line. But all of them knew the data. And the data says if you can intervene here, here, and here, you're going to have a healthier population in Rhode Island in 10 or 15 years if these things happen, which means ostensibly you're going to have a lower pressure on those payers in terms of the pressures they're getting from employers who they work for, or the state, or whoever their clients are, to reduce the cost of care. So why aren't they investing in those early things there? Because they can't justify it on their own bottom line. We have to come up with innovative business and financing mechanisms like we did in Rhode Island, where we're able to pay for some things. And by the way, we assess the payments based upon your market share in Rhode Island, right? So United, Anthem, Cigna, Blue Cross, they all had different slivers, and they didn't only paid for their adjusted rate of the overall population. So none of them were at a competitive disadvantage vis-a-vis their competitors. Again, back to how do you bring mutual stakeholder value into this proposition?
No, I think that's the innovation that, like, when I think about a visionary health leader can think about, is those financial incentives, but also thinking about the continuum of care over time, that these illnesses are not typically acute, they're more typically chronic. And also, if treated earlier, they're a lot less severe in that continuum of care. And in both of those cases, there's an opportunity to be innovative, and there's an opportunity to save money. And we call, it's absenteeism, right? That's when somebody doesn't show up for work. There's presenteeism, where somebody shows up for work and they're not really present. And I kind of feel like that's been me all week, because I've been just lots of moving parts, and being a veteran of Afghanistan and other places, again, policy and all that stuff it's just thinking about the difficulty in some of my fellow veterans, and we've all been reaching out to each other. And so I can't even get away from it just here talking to you. But that's important to my business, that their leader and that the staff is there and engaged and leaning into the work and not leaning away from it. Another question regarding digital transformation, how do you view the opportunity of telehealth wearables, how data can now be shared, and there's so much more data about our health and well-being, that is there an opportunity to radically change how patients engage, particularly with health and mental health providers? And let's just call it health providers, right? Because it should be just one. And how do you see that as impacting the world of health here in the near future?
Good. Just let me jump back for a second. My cousin, Chris McKelvey, was also a veteran of Afghanistan. We've been in contact this last week. He's enormously stressed about his team and all that they're going through as a result of this. So I appreciate that. I think it also, thanks to the military, I think the general population has a much clearer idea about the impact of trauma, thanks to all the years where the military is focusing on this. We now understand what collective trauma looks like. Obviously, my cousins are overwhelmed right now with the potential parole of the man that shot their father. And that's creating a whole re-traumatizing experience for all of them. And so I think just in general, we all have different traumas that we're bringing with us. And unless we address them and can talk about them and get help for them, they can play havoc in our lives in the way that they become counterproductive forces and force us, as I said, back into reactive thinking. So I think it is a lesson to pivot off of. People have been through a lot in the last 2 years with COVID, losing loved ones, being dislocated, losing jobs, security, and so forth. So we have to be under, and this is a moment of time where with our kids, we can really assess the impact on these things. Technology, ironically, can be very, can be a biomarker, right? So how I'm speaking to you, my voice intonation, how I look, my facial expression, again, thanks to investments for national security, we can measure that real time. So you don't even need to be a mental health clinician or psychiatrist to make a diagnosis. Technology can diagnose me through these biomarkers, as I said, with voice modulation and facial expression that can tell you a lot more objectively about how my mental health is, rather than through a subjective analysis by a clinician. That's a game changer, by the way, to your previous question about the lack of number of psychiatrists. The other piece is like Fitbits. We're accustomed to wearing those now, but those Fitbits can have corollaries too for our how our body reflects stresses. And then of course, our geolocation can be a big impact on whether we're going, if you're someone who's been in addiction, you're back to places that are red spots for you, or you're not moving at all. Maybe you're not moving at all, and or the way you use social media. Now, a lot of these things, they'll have to require certain trade-off where people who want the benefit of this technology need to be able to, if you will, give permission to those types of apps that can do that passive monitoring. But if you asked me as a 17-year-old first coming out of drug rehab, if I could have had the Fitbit, the phone app, all of that going for me to give all of my loved ones a dashboard on how I'm doing real time, and an automatic call in if I'm not doing well, and of course I don't want to reach out to anyone if I'm not doing well, that they are able to intervene where I might not want them to, but actually do need them to. That's what technology gives us. So, I've been talking to the Amazons and the Facebooks and the Google Healths, and we can deploy technology in I think, a very finite way, again, at the consent of those that are willing and want this benefit. I think that can be a big difference. In terms of the 988, going back to crisis response, we can monitor based upon where hotspots are around the country in terms of traumatic events, where our response needs to be, thanks to global data technology interfaces. So we can pick that up now through metadata. We can know that, let's say, Northern California, high trauma, down in Louisiana, trauma, if there's a shooting someplace, trauma. That's where metadata can also be helpful in addition to individualized data.
No, thanks, Patrick. That's helpful. And I think about that technology, it's almost like CT scan is to an orthopedic surgeon now, or MRI. This is this evolution of technology that I think folks in behavioral health and psychiatry, when you said, hey, you don't need a psychiatrist to make a diagnosis, and all the psychiatrists are like, whoa, yeah. No, it's an additional tool to assist. You get it. It's an additional tool to assist them to see what's going on and be even better at their trade and at their ability to deliver good health. Brother, thank you. Love you. Have a great weekend. I'm going to turn it back over to Dr. John Langell. Hey to Amy and the kids. Really appreciate you.
Likewise.
Dr. Langell.
Thank you, Dr. Keller, for your passionate moderation on this topic. Mr. Kennedy, thank you for your passionate advocacy for mental health and addiction treatment in the United States and in the world. We wouldn't be as far as we are. We still have a long way to go, but without people like you helping to lead this and thank you for the thought-provoking conversation today. Ladies and gentlemen, please join us next month on October 7th, when we'll be joined by Dr. Art Papier for the next version of VITALS. In the meantime, be well and be safe.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.